Hello everyone, my name is Francis Nam, working at Seoul National University Hospital. Thank you for inviting me to this wonderful conference. Sorry for not being able to visit Moscow due to coronavirus. If I have a chance, I want to visit Moscow in the near future. Today, I'd like to talk about the percutaneous epidural neuroplasty. The topic of this lecture includes rationale for the neuroplasty, method for neuroplasty, and pitfalls. I have no potential conflict of interest related to this presentation. Also, the views presented in this lecture are my personal view. Let's move on to the first topic. This picture shows the dissection of the cadaver in a patient with chronic low back pain who did not undergo spinal surgery. As shown in this figure, adhesions that are difficult to separate even when pulled with a force of about 60 grams were frequently observed in the anterior epidural space. And these adhesions may be associated with low back pain. In this paper, 15 cadavers were analyzed. The adhesions were found mainly in L45 and L5S1 with highest frequency. The simplest way to check epidural adhesion is the epidurography. Normally, the dye should spread in the Christmas tree pattern as shown on the left, but if there is adhesion, filling defects will appear. Filling defects can be seen even in patients with no history of surgery. This article shows the correlation between caudal epidurography with pain severity. The author of this article divided the spinal segments into 15 cells by sectioning each level into the left, right, and central regions from L4 to S3 levels. The number of contrasted cells in each group was counted and compared by drawing a dispersion diagram. The result showed that there was a significant correlation between the severity of pain and the overall contrast flow pattern. Many physicians question whether epidural adhesion is the cause of spinal pain. However, many studies already showed that epidural adhesion can be a cause of pain. Although epidural adhesion alone may not cause pain, spinal pain can be caused by secondary changes due to epidural adhesions, such as compression, pulling of nerve, or venous congestion caused by epidural scars. The cause of epidural adhesion is mainly due to the postoperative fibrotic tissue. However, in a patient who has not underwent back surgery can have epidural adhesion. The chronic mechanical or chemical irritation can cause perineal inflammation and adhesion, which can cause tension, tethering, impinging, or stretching of the nerve root. Eventually, neuropathic pain can develop. Some people have doubt whether epidural adhesion causes back pain. This is a computer modeling study showing the effect of epidural adhesion on the tensile force on the spinal elements. The author of this study designed two-dimensional spine model. They assumed that if there is no adhesion in the epidural space, there is no friction between the annulus and the spinal nerves. In contrast, if there is adhesion, no slip could occur between the annulus and the spinal nerves. The simulation showed that in the no adhesion model, adaptive contralateral displacement of dura can occur, resulting in lower compression by the herniated disc. However, in the adhesion model, higher compression force was produced in the spinal nerves, especially on the DRG, compared to the no adhesion model. In 1989, Dr. Gabor Rex used epidural hypertonic saline to facilitate lysis of epidural adhesion. Since then, the procedure was named as epidural adhesiolysis. Recently, many physicians call this technique by various names. There are various names to refer to this technique, but they are indicating the same procedure. The goals of the epidural adhesiolysis or neuroplasty are lysis of epidural adhesions, removal of barriers to promote the delivery of drugs to the target sites. For neuroplasty, a specially designed catheter is used. Usually, the catheter is more stiff than conventional epidural catheter. This special catheter is spring-wound and shear-resistant catheter. For neuroplasty, a catheter is placed at the adhesion site and epidural adhesion is removed chemically or physically to promote the drug spread to the affected nerve. This picture shows the spread of the contrast media before and after neuroplasty. We can observe that more dye spread to the lesion site after neuroplasty than before. Various types of catheters are used to perform epidural neuroplasty. Rex catheter can be used for chemical adhesiolysis using hypertonic saline or hyaluronidase. Rex catheter is stiff compared to the conventional epidural catheter, so there are opinions that mechanical adhesiolysis is possible on its own. But in my opinion, the effect of mechanical adhesiolysis is small with Rex catheter. If we use a more stiff catheter, we can perform mechanical adhesiolysis more effectively. To do this, we can use NaviCath, epiduroscope, or balloon catheter. This photo shows the Rex catheter. Rex catheter was developed by Dr. Gabor Rex. This catheter has a blunt tip and is designed to facilitate direction adjustment using a specially designed beveled needle. Let's watch a video of cervical neuroplasty using a Rex catheter. First, find the epidural space using a loss of resistance technique. When the needle is placed in the epidural space, insert the catheter. And advance it toward the target site. To make it easier to adjust the catheter's directions, I usually bend the catheter's tip. This is a picture of the NaviCath used in epidural neuroplasty. The NaviCath is a bidirectional steering catheter which is a little stiffer than the Rex catheter, allowing mechanical adhesiolysis. However, since the catheter cannot be placed in the epidural space for a long time, like the Rex catheter, a product called pain control manipulator was also developed to improve this disadvantage. This picture shows the pain control manipulator. Unlike NaviCath, This catheter has the advantage of placing the catheter in the epidural space after mechanical adhesiolysis. So, continuous infusion of hypertonic saline or hyaluronidase is possible. Let's watch a video of epidural neuroplasty using NaviCath. NaviCath is inserted through the sacral hiatus. NaviCath is advanced to the target site under C-arm guidance, and mechanical adhesiolysis is performed around the neuroforamen. Another catheter for neuroplasty is a catheter with balloon tip. There is an inflatable balloon at the tip of the catheter. After placing the catheter at the target site, a physician inflates the balloon for a few seconds to decompress the adhesion. There are two ports on the catheter. One is for guide wire or drug injections. Another is for ballooning with contrast media. This is a video showing neuroplasty using a balloon catheter. Advance the catheter to the target point through the sacral hiatus. When the catheter reaches the neuroforamen, inflate the balloon for several seconds to perform adhesiolysis. This catheter has a balloon which has the advantage of performing more powerful mechanical adhesiolysis. A transforaminal approach is also possible using a specially designed balloon catheter. This video shows neuroplasty using a transforaminal balloon. After placing the catheter to the target site, various medications are injected through the catheter. Hyaluronidase and hypertonic saline are used to reduce epidural adhesion. The local anesthetics is injected before continuous infusion of hypertonic saline because hypertonic saline produces irritation and pain. After infusion of hypertonic saline, steroid is injected and then the catheter is removed. There are 1-day and 2-day protocols in our hospital. The 2-day protocol is used for the patient with severe pain. The difference between the two protocols are the repetitive use of local anesthetics and hypertonic saline in 2-day protocol. Then, what are the results of neuroplasty? In general, it is known that the improvement in dye spread is positively related to the symptom improvement. It is also known that the dye spreading pattern during the neuroplasty is related to the symptom relief. This study shows that the improvement of dye spreading in epidurography is related to patient pain and satisfaction. Group 1 is successful treatment group and Group 2 is unsuccessful treatment group. The proportion of epidurographic improvement was higher in Group 1 than Group 2. The author concluded that the epidurographic change after neuroplasty correlated with pain relief and satisfaction of the patient. And this paper shows the relationship between the spreading pattern of contrast media and clinical outcome in cervical neuroplasty using Rex catheter. The terminology of contrast runoff means the spread of contrast from the neuroforamen to a nerve root. You can find the contrast runoff in both figures. The success rate was significantly different between the contrast runoff group and no runoff group. Therefore, the author of this study concluded that the contrast runoff should be observed during the neuroplasty. And this paper shows the correlation of the contrast spreading pattern with the functional improvement. The patient with extraforaminal spread in post-adagio lysis showed a better improvement in ODI and SF12 scores compared with patients with intracanal spread. As you can see in these figures, the more extraforaminal spread, the better clinical outcomes in ODI score and SF12 score were found. There is a lot of supporting evidence for the effectiveness of neuroplasty. This kind of article is published in the Pain Physician Journal. Epidural neuroplasty is effective for post-lumbar surgery syndrome, central lumbar spinal stenosis, and low back pain. Some complications can occur related to these procedures. The immediate complications include bleeding, dural puncture and headache, breakage of catheter. The delayed complications include bowel and bladder dysfunction, sexual dysfunction, paresthesia or numbness, and infection. This case report shows a subdural hematoma after neuroplasty. The proposed mechanism of hematoma is that during the neuroplasty, CSF leakage might have occurred due to dural tear, which could lead to intracranial hypotension. Also, the continuation of intracranial hypotension might lead to subdural hematoma. This case report shows the catheter breakage during the neuroplasty using Rex catheter. When the catheter was pulled out, the patient experienced severe burning pain on the buttock. The catheter was trapped in the left foraminal portion of the vertebra. Finally, the catheter was broken. The broken catheter tip was surgically removed. This is a case report of coda equina syndrome after neuroplasty. In this case, 10% hypertonic saline was used. The patient complained of numbness in perineum, weakness of left leg, voiding difficulty, and fecal incontinence. This probably resulted from the intrathecal spreading of the hypertonic saline. The patient was finally recovered 1 month after the procedure. This case report describes the acute monoplasia after epidural neuroplasty. Upon arrival in the recovery room, the patient developed complete motor paralysis of the right leg. An urgent MRI was performed. However, there was no hematoma or suspicious lesions around the right lumbosacral plexus. The patient could finally discharge 3 weeks after the procedure. Total 40 milliliters of fluid was injected during the neuroplasty. This neurologic complication was thought to resulted from the large volume of fluid injected. This is the summary of this lecture. Percutaneous epidural neuroplasty is an effective method for low back pain. Various catheters can be used, and procedure-related complications should be kept in mind. Thank you for your listening.